Greetings, everyone, and welcome to the EKG case of October 23rd. And just finished the weekend shift, Saturday, Sunday. It was diarrhea weekend. Nothing but gastroenteritis the whole weekend, I think. And didn't see anything interesting. Of course, as soon as I got home, I got an email, which was a pre-hospital EKG that was being transmitted to university. And some of my colleagues have set up a system so that I get copies of those EKGs coming to my email. And wouldn't you know, the first case, it seems, after I left was an inferior wall STEMI. So I missed it entirely. Not that I'm going to stay later just for that case, but anyway, it was time to get home. So I figured what I would do is talk about inferior STEMI, and so let's start with this case. 54-year-old man. This is not the case that I missed, but it's a very similar case. 54-year-old man who comes in to the hospital, to the emergency department, complaining of indigestion. So as you know, since this is an EKG series, anybody presenting with indigestion must have an inferior wall STEMI. Always think about the possibility of inferior wall ischemia with anybody presenting with reflux or indigestion. And I'll digress for a moment just to remind everybody listening that the most common misdiagnosis sitting on the chart of malpractice cases for a missed MI is peptic ulcer disease, indigestion, reflux, and so on. So before you ever write indigestion or reflux on a chart and send somebody home, just think twice that you might be dealing with one of those inferior wall ischemia patients. And anyway, this is a no-brainer because this patient actually has a diagnostic EKG. So even with his chief complaint, nobody's going to miss this. This guy's got a clear-cut, where's my cursor? There it is, an inferior wall STEMI. So no big surprise. So the question comes up with this acute inferior wall STEMI, how do you want to treat this patient? So you're probably going to give aspirin. Hopefully you're going to give aspirin. And we have gotten away from beta blockers, which is good. You might start some heparin. And if you're in a place that gives thrombolytics, you're probably going to start getting the thrombolytics set up. If you're in a place that does cath, you're going to call the cath lab and get them mobilized. And then if he's having pain, with most STEMIs, you're going to give the patient some nitroglycerin. But there's a problem here, and something that you need to remember. Anytime you're dealing with an inferior wall STEMI, you've got to consider the possibility that you're also dealing with right ventricular extension of that inferior STEMI. In other words, right ventricular MI. And the reason you need to remember that is because if you have a right ventricular MI, you need to stay away from any medications that are going to decrease the preload. If the person's got a right ventricular MI, the only thing that's getting blood to the left ventricle is preload. The way I think of it is that the purpose of the right ventricle is to do nothing more than simply pump blood to the left ventricle so that the left ventricle can produce a blood pressure. It's a simplistic way of thinking of it, but it works. Now, if you have a right ventricular MI, you've lost flow to the left side of the heart, good flow, and so you need preload to just move blood to the left side of the heart. If you give a preload reducer and you've got a knocked out right ventricle, you're not going to get any blood to the left side of the heart, and that means your blood pressure is going to plummet. And when you give nitroglycerin to these patients, their blood pressure is really, really going to fall. So the key point for this week is always consider right ventricular MI when you've got an inferior wall STEMI. Now, is there anything on the 12-lead EKG that can tip you off to the fact that you're dealing with right ventricular extension of the inferior STEMI, and therefore you have to stay away from nitrates and anything else that decreases the preload? Well, I would say that this patient actually has a diagnostic EKG, diagnostic for right ventricular infarction, and here's the simple EKG pearl. When you've got ST depression in lead V2 with ST elevation in V1, you're done. This person has a right ventricular MI. All right. The way you can think of it is lead V1 essentially is a right ventricular lead because it sits on the right side of the chest. So if you have ST elevation in V1, ST depression in V2, that person has a right ventricular MI. Let's look at another case here. This person has an inferior wall STEMI, and you look up here, and there's ST depression in V2 with ST elevation V1. That's a right ventricular MI. Here's another case. It's a pre-hospital EKG. Person's got an inferior wall STEMI. There's ST depression in V2 with ST elevation in V1. That is enormously specific for a right ventricular MI. You stay away from nitrates with this particular patient. Now, here's another case, and this person has a right ventricular MI also. It's just a little bit more subtle. There's an inferior STEMI, there's ST depression of V2, and in this case, there's no ST elevation in V1, but there's an isoelectric segment in V1. There's no ST elevation or depression. It's just isoelectric in V1. When you've got V2 depressed, V1 and V3 are isoelectric. You're looking at a right ventricular MI. Let me give you another case. Inferior STEMI, ST depression V2, isoelectric in V1 and V3. That person's got a right ventricular MI. Now, there's another thing that you can do if you have any doubts. You can always just do some right-sided leads. Essentially what you do is you just take V1, 2, 3, 4, 5, 6 and put them across the right side of the chest instead. And this is the only image I could find off Google. And so there's your V6, 5, 4, 3, and for whatever reason in this image, they put V1 and V2 here. What I like to do is just do a complete mirror image of the leads. So I put V1 here, V2, 3, 4, 5, 6. So right across the right side of the chest, you put all of the leads in the mirror image of what you would normally put on the left side of the chest. So you've got a right-sided set of leads, and then you repeat the 12-lead EKG, and what you look for is ST elevation in any of those leads. So here is a person who had a repeat 12-lead EKG. Actually, if you go back, this is the patient, and what we did was we took all of these V leads and we just put them across the right side of the chest in a mirror image. There's lead V1, 2, 3, 4, 5, 6 laying across the right side of the chest, and there's clearly ST elevation in these leads which are on the right side of the chest. So you just confirmed that this patient does indeed have a right ventricular MI, and that makes it very, very easy. So when in doubt, if you have an inferior STEMI, just do right-sided leads if you have any doubt, and look for any ST elevation in those right-sided leads. And if you see ST elevation in those right-sided chest leads, you've got to stay away from nitrates, because if you give nitrates, the blood pressure may plummet. Instead, have a bag of IV fluids ready to go, because those patients need preload. They're going to end up needing some good IV fluid boluses to maintain their blood pressure. All right. So once again, when you get your 12-lead EKG, how do you know you're dealing with right ventricular MI? Well, first of all, you're going to look for an inferior STEMI, and if the inferior STEMI patient has ST depression in lead V2 with ST elevation in V1, or if there's ST depression in V2 with an isoelectric segment in V1 and V3, I should put that up there, in V1 and V3 together, then that person has a right ventricular MI. Or you can just do it the easy way and just do right-sided leads every time you have a patient with an inferior STEMI. It's important. It makes a big difference. Sometimes I hear wacky people who say, well, why do you need to worry about that? Just give them nitroglycerin, and if they drop their blood pressure, you'll confirm that they've got a right ventricular MI. Well, in my opinion, that's stupid. Why would you want to drop the blood pressure in somebody who's already having an infarction? What you'll do if you drop their blood pressure is you'll make the patient feel awful, diaphoretic. You might extend the infarct, extend the ischemia, decrease perfusion to the brain and other vital organs. Even though it's only for 5 minutes until that nitroglycerin wears off, why do you want to make that patient worse? That's just dumb. So don't bother doing that. Don't use nitroglycerin as a test dose. Just look closely at that 12-lead EKG or do right-sided leads and make the diagnosis. Use your brain, not nitroglycerin. All right? So that's it. Think about right ventricular MI every time you see a patient with inferior STEMI, and when you see the right ventricular involvement, stay away from nitrates, have a bag of fluids ready to go. That's it for October 23rd. Talk to you next week.
This is a case of a small piece of metal that has adhered to the cornea. We see this very often in ophthalmology. Sometimes you can get them off just by rubbing with a Q-tip, but if that doesn't work, then you can use a needle to kind of scoop the thing off. Some people like to use a 18 gauge needle and some like a 30 gauge. I prefer the bigger 18 gauge because I feel it's safer, less likely to penetrate through and create a perforation. So I've scooped this thing off, and you can see that there's still a metal rust ring. You can try wiping that off with a Q-tip, but if that doesn't work, then you can use something like a diamond burr to actually buzz this thing off. So this is a hand-powered or battery-powered diamond burr, very similar to a Dremel tool, and I'm just buzzing off some of that rust in the periphery. Now you need to be careful with this as well, as you don't want to penetrate into the eye. But here is the leftover rust ring. It'll work itself out.
Watch more eye videos at routeatlas.com.